Hi, I'm Naja Williams, a licensed clinical social worker in the Kimmel Cancer Center at Johns Hopkins, and a member of the Harry J. Duffy Patient and Family Services Program. On behalf of the Kimmel Cancer Center at Johns Hopkins, I am pleased to welcome you to our 8th annual Cancer Survivorship Conference, Session 5, Maximizing Survivorship Through Palliative Care. This is our last in a series of October workshops offered to you through the generosity of the Harry J. Duffy family, for which we thank them. Some details about this virtual workshop. You may offer a question or comment through the Q&A button, although given we are over 150 in attendance, we may not be able to specifically answer each one. However, knowing our speaker, I am confident that she will do her best to address your questions. Please help me welcome Dr. Danielle Doberman. Dr. Doberman's area of clinical expertise includes geriatrics and hospice and palliative medicine. Dr. Doberman serves as the course director for both the Time End of Life Palliative Care course and the Palliative Care Clinical Elective at Johns Hopkins University School of Medicine. She is the program director for the Palliative Medicine Fellowship and serves as the clinical medical director for the Palliative Medicine program and clinics at the Johns Hopkins Hospital. Thank you so much, Dr. Doberman, for sharing your time with us today and helping us learn more about how palliative care can be a useful tool in cancer survivorship.
Thank you for inviting me, Naja, and for the Duffy family for supporting this event.
Well, why don't we dive right in? I would love for our viewers to understand more about what is survivorship.
It's a really excellent question. And I think with a lot of things in medicine, believe it or not, it has a lot of different definitions. So the National Cancer Institute defines survivorship as someone from the time that they've been diagnosed uniquely through the end of their life. And also says that family members, friends, and caregivers who are impacted by the entire experience of illness are also part of the survivorship experience. I think, probably many of us would choose a different definition of survivorship, probably from the time somebody ends all of their active cancer treatment and is deemed to either be in remission or to be cured. So that's probably what most lay people consider a survivor. Some people actually don't like the term survivor because people feel it has an advocacy overlay. And that for somebody to use that term may mean that they have to somehow also hold a mantle of doing something, going on fun runs or other things like that.
A little bit of pressure.
A little bit of pressure. And I think also increasingly survivorship as a field of medicine and starting to have a unique research base to it is increasingly prominent amongst many fields of medicine because thank goodness more and more people are being cured and more people are living with disease that's controlled.
Right.
Cancer is being treated as a chronic illness for many people. So there are fields of divisions of primary care. There are portions of oncology where survivorship clinics have grown up. And now there's more and more research, especially pediatric patients who have survived. And what are their needs now as young adults who are survivors?
Right. Can you tell us why is it so important that we differentiate survivors and have this survivorship concept?
Yeah, so whether it's the pediatric patient who's grown up or the adult patient who may now be cured of their illness, the treatments that we use to clear the body of the cancer can have lasting ramifications. Physically, emotionally, mentally. So physically, some patients will have fatigue that goes on for many months or many years afterwards. Some people will have sleep disturbance, anxiety. The treatments themselves can lead to neuropathic pain, nerve pain, or other forms of pain. Sometimes people will be left with residual cognitive changes for many months, especially if they've had radiation to their head, brain. Some people have had disfigurement because of the surgeries that we do to try to cure them. This can be very emotionally upsetting, especially if somebody is having a head and neck cancer. But also, clearly, a lot has been written about women who may have a breast or gynecologic cancer, and even men who may have, whether it's a cancer of the genitalia or not. Many times, people have been left with physical disability or financial disability, inability to return to work, which can lead to a lot of emotional disruption in their lives. We also know that there's new health surveillance that's needed for a lot of patients, whether it's an increased schedule to look for return of that cancer or new susceptibility to new cancers. We know that some of our treatments lead to changes in heart disease risk. So having physicians, whether it's oncologists or primary care doctors, who are aware of this, having open, honest conversations so that patients are informed and can be their own best advocates is important. There are some fertility challenges and, of course, the financial toxicity that people end up with, which I think we as doctors in the field need to be honest about and start talking about with people.
Right. And you mentioned the primary care doctor or oncologist. Which doctor runs kind of that survivorship care? Is it a collaborative effort? How does that work?
So I think for each patient, that's going to be different. At the local level, some people who can still get care at specialized cancer centers like we have at the Sidney Kimmel Cancer Center, there may be survivorship clinics. Many specialized breast cancer centers will have a survivorship clinic. Many bone marrow centers will have a survivorship. Some primary care clinicians really enjoy taking care of highly complex patients. They may have a social worker in their office. They may be perfectly positioned to be that person captaining the ship and partnering with somebody who has survivorship needs. So I think at the start of treatment or in the middle of treatment, as somebody is having that long road view of what is it going to be when I'm cured or I'm in remission, what are my next steps, to say, who is that team of people that I'm going to surround myself with? And for some people, it may be their primary care doctor and the oncologist. For some people, it may be the nurse navigator and their primary care. So I think it's understanding what are the capacities of an individual community. We do have a survivorship clinic affiliated with Hopkins at our Green Springs station. And there are other clinics in other locations. It's also important, I think, to ask your treatment team, whether that's your radiation oncologist or your medical oncologist, surgical oncologist, is the treatment plan that I'm undertaking placing me at risk for some long-term physical symptoms? And if the answer is greater than 50% yes, then the question is, will I need somebody specialized going forward who can help with pain or symptom management? And that may be a reason to engage with palliative care during the active treatment plan.
Right, right. I think that's a great segue into, laying that foundation of what survivorship is and why it's so important and why we advocate so much for these conferences, and speaking to a little bit about what exactly is palliative medicine and defining that for the viewers.
Right, so palliative medicine is a field of medicine that focuses on mind, body, and spirit. So it's specialized care for people living with serious illnesses. And it's focused on relief of symptoms and stressors of illness. So the goal is really to provide improved quality of life, improved integration of care, and the patient is really the whole family unit.
Right.
So, and however the patient defines family. So palliative medicine is focused on it's needs-based care. So it's focused on whatever symptom the patient's having. It's not prognostically. So it's not focused on patients who have a certain prognosis. So any patient can have a palliative care referral at any point, at any stage in an illness, from diagnosis onwards, and at any age. So children can have palliative care, and it can be provided right alongside curative care. So in the cancer treatment world, sometimes people may have a stage 1 disease, they may have a stage 2 disease, but perhaps the treatment that we're using is a platinum-based therapy. Those are very highly emetogenic, we say, very highly causing of nausea. And maybe somebody, maybe from previous life circumstances, doesn't tolerate medications well. Or maybe somebody has a previous car accident and they already have some chronic pain issues and now they're getting surgery. Maybe they're a challenging patient for the oncologist to medicate. And they might benefit from a specialized group helping with their treatment plan. So
when you say group, what does that entail?
yeah, right, exactly. So palliative medicine tends to be provided by a team, tends to be a team-based program in many locations, both inpatient in the hospital and outpatient in the clinics. So just as I said, palliative tends to do what we call whole patient care, whole patient assessment, evaluating what are somebody's sources of illness or suffering in the body, in the spirit, in the mind. So many times teams are made up of chaplaincy, they're made up of social workers, they're made up of nurses, nurse practitioners, doctors, pharmacists. In some institutions, there may be physical therapists looking at ways to maximize rehabilitation. So again, thinking about the entire depth of what it means to be a person living with a serious illness, but how can we maximize quality to that life? I, as a doctor, don't know everything about, how to get resources out to somebody's home, right? Maybe somebody has PTSD from having been in the military and maybe is having flashbacks from having their cancer surgery. You, Naja, as a social worker, are going to serve them, and we as a partnership are going to serve them better than either of us alone.
Right.
Right. They might need therapy with you, maybe some of my medicines, if talk therapy isn't working alone. So it's the partnership that palliative tries to really bring to care plans, working alongside the primary team, alongside the oncologist and the nurse practitioner in oncology.
It's a concept to me that sounds very patient and family centered. And when you described survivorship, it also sounded very individualized. So putting those two together seems like a great recipe for maximizing quality of life.
Exactly. And I think really what we say is start where the patient is. Right. Maybe the referral we get says, please help the patient with pain and nausea, but maybe for that patient and their family, they're saying, no, food insecurity and how do we pay for these medications is actually top of their agenda for today. So, patient-centered care plans, starting with where the patient is, what do they want to talk about? What are their needs? Let's make our palliative care plan the patient's plan of care.
Right, right. I do want to remind our listeners, if you are participants, if you'd like to ask any questions, please do so in the Q&A box, so that we can make sure that we address all of our issues and questions that you guys have. One of the things that I really like about what you're describing is this idea of starting at diagnosis. It's having palliative care be something that can be brought into survivorship. How does someone go about getting their provider or getting their team to introduce palliative into their plan?
Yeah, so in some cancer centers, the palliative team's outpatient, the clinics, are very small. There's not that many palliative providers around the country. So in some places, the palliative nurse practitioner or doctor only sees patients of that particular oncology practice. What I would recommend is that if somebody feels they have symptoms or needs, which maybe, excuse me, they feel could be addressed by palliative, ask the nurse in their oncology clinic, the nurse practitioner, the doctor for a referral, or ask if the palliative team sees patients as part of routine course, or can you self-refer?
Right.
In some locations, a self-referral is allowed. You also can just look online and Google. You can call the palliative clinic yourself. There is a national website called getpalliativecare.org. It's actually a directory of all the palliative care practitioners around the country who provide service in hospitals, in clinics, in nursing homes. And you can even telephone and find out which providers serve your zip code. In some areas, there are clinics which will accept patients independent of any affiliated oncology group.
Wow.
And so sometimes, unfortunately, this takes a little bit of telephoning around on behalf of the patient.
Right. What can someone expect? Say their provider or they self-refer, they start to involve palliative care in their plan. What can they expect with a palliative care consult or meeting, either with the palliative care provider or that multidisciplinary team?
So ideally, their palliative care doctor and their oncologist will communicate back and forth. Typically, only one of the two physicians will write prescriptions for the medications they need. This is a safety mechanism, so people don't have interactions between the chemotherapy and the medications which are being ordered. It's also a safety mechanism, so somebody doesn't have too many pills from the pharmacy. Most of our insurances require pre-authorization, and in today's climate, there are limits on the number of opioids. Some people say narcotics, which our insurance companies will pay for. Some of the states we live in will only allow certain numbers of opioids to be released from the pharmacy each month. And many of us have pharmacists that have to register the need for prescriptions with the state, stating that somebody is a patient receiving cancer treatment. So it's often very helpful that we can work collaboratively with the oncologist and say, will you be writing the prescriptions? Will we be? We can't have too many prior authorizations and state requests going in.
Right.
This is done for safety. It is sometimes a little bit burdensome for the patient because we can't, we have to have a few days before refills are needed.
Right.
Let's see, we also, because our clinic tends to have a social worker, some of the oncology clinics do too, we try to really listen to what a patient wants about their healthcare and what the family needs. Maybe they have a best friend who they bring to clinic visits, and that best friend will walk alongside them for all their treatment. So maybe we suggest that they have that best friend written down as their healthcare agent, as their surrogate. So we try to do a lot of anticipatory planning.
Right.
Some people find those conversations intense, but we feel it's helping to make a safety net around the patient. If God forbid they ever were in a situation, they got COVID, if something happened and they couldn't speak for themselves, we would like to have the healthcare record documenting what their values and goals are when it comes to their healthcare wishes.
Right.
So in our clinics, we do a lot of development of living wills, a lot of development of what people call advanced care planning. We like to have surrogates written down. Again, not because we think anything negative is going to happen, but we feel this is a rainy day fund. You tie a bow on it, you tuck it in a drawer, and it's there. We all have car insurance, and God forbid anything happens, right? We all pay for it, you tuck it away.
Right.
And that's, you know, it's just part of what we do to keep our families safe. And these are the discussions we need to have to tuck it away. So clinic means being seen by multiple different people, nurse practitioner, doctor, social worker, sometimes chaplain in some clinics, and working on streamlining medications and sometimes having difficult conversations.
It's something that to me sounds like could also go outside the realm of oncology, right? We all should be advanced care planning and just have somebody who knows things we would and wouldn't want done. I've got a question from one of our participants, I think that just goes right into this, in that is palliative care something only for oncology patients, or is it something that other people can benefit from?
Correct. So across the country, palliative care is delivered for anybody with serious illness. So there are clinics around the country for people with any serious illness, such as advanced heart disease, advanced lung disease, patients who have neurologic ailments like Parkinson's or ALS, which is also called Lou Gehrig's disease. The Alzheimer's Association has recommended palliative care evaluations for all forms of patients with advancing dementia. But the Alzheimer's Association has actually recommended palliative evaluation for those with early stage. So again, people can have important conversations while they are fully participatory.
Right.
And also recognizing that many illnesses have potential for physical symptoms. That while we are bringing people in and out of clinic, in and out of hospital, we're often, as a medical system, focused on the big fires,
right,
the pneumonia, the heart attack, what have you. But many times there's these smaller, equally important challenges, like the need to take off work, or how do we tell the children what's happening, or who's even picking the children up at school? this kind of thing. So,
right, right. It's a service that I think sounds wonderful, and I think one of the things that, and the environment that we're in, especially economically, I wonder, is this something that insurance covers? Does it cover it when you are going to those outpatient clinics, or if you are inpatient, as you've mentioned before, is it something that's covered under insurance?
yes, so palliative care is covered by all major insurance companies and by Medicare. And it's fully, just like going to the GI doctor, gastroenterology doctor, it is fully covered. I did want to say there are some unique populations under oncology that that have ailments that tend to last much longer after active treatment ends. And those are patients who have graft versus host disease, or chemotherapy-induced neuropathy. Some people who have radiation changes for a long time. And sorry, I hear some feedback.
There's a little bit of feedback as well.
Yeah, okay. And also, so if somebody also has been part of a palliative clinic, many times the clinic will try to make arrangements even when they stop active treatment to perhaps help them if they're on opioids at the end of their active treatment. Many times the palliative clinics will try to make arrangements to wean them down off of the opioids after that treatment is over.
For those people who may not be able to get to a clinic, or maybe they're not inpatient, and they may be a little bit more homebound, does palliative care come to your home?
Excellent question. Yes, around the country there are providers bringing palliative care into the homes, either as home-based geriatrics, home-based primary care, or home-based palliative care. The programs have many different names. And again, that getpalliativecare.org that I was telling you about, many times will list home-based providers. Not to be scary, but some of the specialists in providing symptom control, often in the community doing home visits, work for hospices. And there's something called bridge programs or upstream palliative. Many of the hospices in the Baltimore, Washington communities specifically are offering home-based palliative care for people with serious illness who have difficulty getting out of their homes. This is distinct from hospice care. This is home-based palliative. And so if people feel that themselves or their loved ones could benefit from additional emotional support, logistical support from a social worker, or symptom support from a nurse practitioner or doctor, they could call the hospice that serves their zip code, sometimes that's more than one, and ask if the local hospice provider has a home-based palliative program or a bridge program, those are the various words, or home-based geriatrics. There's independent geriatric providers in some areas as well that provide a very similar service, and that might be a way to achieve the same goal.
I think it's so interesting that you have pointed out that difference between hospice and palliative. People kind of hear palliative and they get fearful, when in reality it's such a valuable service, especially to survivors, cancer survivors, or those living with a serious illness.
That's right. And Hospice really is an insurance benefit. You know, Medicare funds it. It's a carve out on many private commercial insurances. Hospice is for people whom prognosis has been agreed upon to be unfortunately limited to a relatively limited number of months at the end of life. When two doctors have agreed that prognosis is less than 6 months, give or take. But palliative is independent of prognosis. It's merely when people want to focus on quality. It's any time from diagnosis onward. And people can have many, many years with the care of a palliative provider, or even just a palliative focus to the care that they're receiving from their regular doctors.
Right. I really appreciate that definition. I think I've got a participant who was offered palliative care and said no out of fear because they thought it was just hospice. So I think for those listening, that differentiation may make them think that palliative would be beneficial, especially if they're living with a chronic pain or have pain management issues related to their cancer diagnosis.
Right, and I think, you know, palliative teams have really great skills at symptom control. They're adept at complex pain regimens, and there's an awareness of how you mobilize services in the community for people who have serious illness. And then there's a degree of complex skilled communication. And so that's a reason to look into palliative. Those are some of the same skills in hospice, but again, not being utilized that way. That's some of the differences also from primary care. You can find primary care providers, you can find oncologists with some of those same skills. Oftentimes though, the oncologists have, their focus is really on the cancer care. So being able to partner with palliative is ideal. For people who are no longer under active treatment, most palliative teams honestly will attempt to wean opioids. That is in our literature for what to do for somebody who's no longer receiving active treatment. And probably people should know that going up front. There are people who have history of prior substance use disorder and then who have had active cancer therapy. For those individuals to wean may be more complex, and some palliative teams will refer to specialists in addiction medicine, because for some people to wean may require a specific pain psychologist or may require medication-assisted therapy, such as things like methadone or buprenorphine, and a different type of therapeutic relationship with a slightly different team, addictions medicine team. So occasionally if somebody has a complex pain regimen after recovery, the palliative team may assess that their form of interdisciplinary care may not be fully adequate, right, and refer on to a different type of interdisciplinary team with a slightly different focus.
If we have some of our participants on here who are thinking, you know, this is really something that I would love to incorporate into my care plan. Does their either primary care doctor or oncologist, do they have to order palliative care to agree that I can have it? Is it something that I can have maybe even if my physician doesn't order it?
Right, that's a good question. So the reason for a traditional referral is mostly so that we as doctors and nurse practitioners, whenever a referral is made from one doctor to another, your provider usually sends medical records and explains, here's what treatments have been. So when somebody comes to see me and says, I have residual pain here, it's very helpful, especially if somebody has been treated outside of our medical system, or if you are seeking palliative services at a different clinic, and your medical records aren't in that shared electronic record. It's very helpful for us if we can see, well, what was your surgery to the area that is bothering you? What was maybe radiation to this area? Sometimes the pain might be directly where you had a scalpel, but sometimes it's what we call referred pain. So if you think of sciatica, sometimes people have pain that goes all the way down their leg, but it's from a nerve in the back. That's referred pain. So for us, it's very helpful to actually either see images if we have a shared electronic record and we get a report, Ms. Williams had an MRI on June 3rd and she had a follow-up MRI September 2nd. So that's the reason there's kind of a traditional way that we get used to our heads in processing a patient. It's not that we don't trust what the patient says, but there's a way that we receive data,
right?
For lack of a better word.
It gives us a big, clear picture of what's going on with them to better address whatever their needs are.
Correct. And then it's helpful for us to know who's your new point person, right? So if we feel, for example, that you might benefit from an adjustment in sleep medications, or you might benefit from acupuncture, or you might benefit from an adjustment in an antidepressant, but our pharmacist says that might interact with other medicines that you're on for blood pressure or heart disease, we need to give that feedback back, because maybe we don't want to make our adjustment until it's approved by the physician who's prescribing those other medications.
Right.
So we want to be very collaborative.
Right. I think I hear a lot from our patients about neuropathy and the challenges of that. Can you speak a little bit to ways that either palliative medicine can help manage those symptoms through survivorship after going through treatment?
Yeah. So the chemotherapy-induced neuropathy, peripheral neuropathy, is a big challenge. There are medications that can be tried, oral, tablets, and the like. There are some topical medications that can be placed. I think one of the greatest parts about the medications is to know from anticipatory guidance that they don't act right away. So I think many other medicines that we take, we tend to see change in a few days. The medications for neuropathy will take weeks to months to work. So many times people had their neuropathy start to develop over several weeks and several months. It takes several weeks and several months to then start to recede. So unfortunately, neuropathy is not something that we can impact very quickly or very easily. And I think having an honest discussion about it is important. So even when we in palliative prescribe a medicine, it's to know that the medicine I give you today is not going to be at full impact for many, many weeks. And I think even as I continue to adjust it, it's still many, many weeks. So I think that discussion is not always held with patients. Maybe even palliative clinics, it's not always, sometimes we know it in our brain, but we forget to say it. That the timeline for change with neuropathy is a challenge, because nerves, the way that they get injured and then heal is not a fast timeline. It's not like a bone which reknits quickly. So it's more of a partnership of support with someone, and what we say, providing anticipatory guidance, so that people are aware that we are trying and we'll keep trying, and we have other medicines and other tricks, but that we have to try this and then kind of wait a little bit.
Right.
There are things that can also be done to augment nutrition, these sorts of things, but neuropathy is not easy.
Right.
It's not easy.
I'm excited of all of the things that Palliative has to offer, and especially with our survivors and those living with serious illness. I'm just curious, in the medical field, do you think that there'll be more of these type of providers in the community coming soon?
I do think especially awareness of survivorship is definitely coming. And I know that seminars for primary care doctors, especially awareness of what to screen for at annual exams, is definitely a growing body of information. So fatigue alone, decreased stamina, I think is just awareness of that as one thing to ask about, and to say, this is not in your head. You really are experiencing this. Let's run some blood work. Let's check that nothing is going on. But then, let's work on good nutrition. Let's work on sleep habits and things like yoga. There's been some studies on looking at exercising regularly, and it doesn't mean necessarily getting on the treadmill, but just taking around the block walk, things like that. So there is more information coming. I think also the very appropriate success of breast cancer centers and their survivorship work, the nurse navigators coming out of breast care center. Commission on Cancer has had, to receive accreditation, they've said that they would like a survivorship plan. They would like, when people graduate, that you get a list of kind of what you should do next, to empower people to know what's coming. I think some people feel that goes both ways. Like, why are you putting this on me, the patient? Shouldn't my doctors be telling me what to do?
Right.
But I think also to say, like, awesome job. Like, you've been doing great. You've been coming to all these appointments. You've been going to all your radiation treatments. You've been sitting in the chair and bringing a friend. You've been carrying hand sanitizer everywhere. You've been doing your part. This is amazing. And unfortunately, your part doesn't end when the treatment ends.
Right.
Like, the whole body is a temple. You got to keep carrying the temple around. So.
I've taken part in some of those survivorship clinics, and I think what I've learned from those patients is they actually love having that knowledge base of what to expect next and how they're doing, because so often when they get diagnosed, there's a whole team of people there, right? And then all of a sudden they're done with treatment, and that team's on to the next person. So.
Right. And I think also, the reproductive challenges for our younger patients, that really, we can't not discuss that, because somebody has, you're so overwhelmed, understandably, by your new diagnosis, but to do cryopreservation so that your fertility, there's a chance, but of course still there's concerns of conception, and then there's also the financial costs for doing in vitro and some of these other things. Although I do think some insurance companies are now paying equally, but that's somebody has to have an honest discussion up front with younger patients. And just because a younger patient already may have some children doesn't mean that they don't want future children or don't want future children with a different significant other. Mm-hmm. So I think, again, for us to have these important conversations up front.
I'm so sad that we have to end our discussion because I could talk to you about this all day. So thank you so much, Dr. Doberman, for giving your time and insights to our survivors, their caregivers and friends. Thank you so much to all of you for joining us for this series of workshops. As always, we here at the Harry J. Duffy Patient and Family Services Program are here to support and assist you during your treatment. Please contact us if we can be of service. In early November, you will receive a survey to let us know how we did. Please take the time to fill that out and get that back to us. Currently, we are in that wonderful season of open enrollment for Medicare, and Maryland Health Connections will be opening up their open enrollment shortly. Thank you so much for taking the time to be with us, and everyone have a great day.
Thank you.